people who are going to continue to join in the next couple of minutes, but what I thought I'd do is just get started and introduce myself and just tell you all a little bit about the seminar series. My name is Sapana Patel. I'm a faculty member in the Department of Psychiatry at Columbia University, and with my colleagues and co-leaders of the Implementation Science Initiative, Dr. Rachel Shelton and Natalie Moyse. We're so delighted to see so many of our colleagues joining us today from near and far. Just a reminder to everyone that our Implementation Science Seminar Series will be held monthly through June of 2021, and will feature national experts who lead research focused on health equity, racial justice, and implementation science. Just a few notes before I introduce our speaker for today. We've taken measures to ensure that we don't experience any intrusions during the seminar today. So we'll be muting everyone except for the presenter. And if we have time for questions at the end, I'll ask if you can please add your questions to the chat, and I'll help moderate this portion of our seminar for today. I also just want to let everyone know that we'll be recording today's presentation as well. So without further delay, it's a great pleasure to introduce my colleague and former mentor, Dr. Roberto Lewis-Fernández, as our speaker for today. Dr. Lewis-Fernández is a professor of clinical psychiatry at the Vagelos College of Physicians and Surgeons, the director of the New York State Center for Excellence in Cultural Competence and the Hispanic Treatment Program, as well as co-director of the Anxiety Disorders Clinic at the New York State Psychiatric Institute. Dr. Lewis-Fernández is an internationally known researcher, focuses on the development of clinical interventions and novel service delivery approaches to help overcome disparities in care of the underserved cultural groups. And today, Dr. Lewis-Fernández will be presenting on disparities in mental health treatment engagement, barriers, and potential solutions. So with that, I'd like to welcome Roberto, and over to you.
Thank you very much, Sapana. It's a special pleasure to be introduced by you after all the years of working together. Thank you for a wonderful introduction. I'm very happy to be speaking on this topic, which is near and dear to my heart, involves engagement of groups of people, individual people in care. I'm going to give a particular focus on major depression, but most of what I have to say will apply to many mental health conditions as well as other physical health conditions as well. The perspective, though, from which I'm coming is mostly mental health. This is an outline of what I will try to cover in the time. I realize it's a lot, so I will try not to spend a lot of time on each one. But first, I'm going to get us to a common definition of cultural and structural competence and what disparities means. I know most of us have a certain understanding of that, and so this is more like to make sure we all have a common language. Then I'll mention the different levels to understanding disparities at the different types of levels of provision of care, and then focus on access and availability of services, quality of services, this time around only focusing on engagement, what's in yellow. I will not focus on assessment or outcomes, and then spend, it seems funny, but that's just the first half of the presentation. The second half of the presentation is actually strategies to increase engagement. The outline is uneven with respect to the content of it. So my first position is the slide is a theoretical frame that I want to convey, that I'm coming from the position that we are trying to apply cultural and structural competence to achieve disparity reduction in quality of care, so that we overcome gaps and disparities in care among different populations, particularly focused on racial and ethnic groups, but this could apply to any other aspect of a social group that is receiving disparate care, be it by sexual orientation, gender, language, any number of other social characteristics. These are two definitions from two different federal services about what cultural competence means. They both emphasize the fact that there are multi-component efforts. So in this sense, this one speaks of behaviors, attitudes, and policies. So it's individual, programmatic, and as well as systemic. This definition is from the Department of Health and Human Services. And they also not only speak of multiple domains or components, but they also speak of multiple levels at which cultural competence ought to be included. And this is the systems, agency, or among professionals. So either at the full level, including down to the individual providers. And the limitation of this approach is that it only focuses on the idea of cross-cultural situations, as though people who were of the same background, if you will, didn't sometimes face some of these difficulties. So the Office of Minority Health has a slightly broader definition, which I also like, which emphasizes the multi-pronged aspect, the multi-component aspect, as well as down here in the examples, the different components of the definition. But it focuses on clients with diverse values, beliefs, and behaviors, which I guess I'm stipulating is everybody. Everybody has a different set of different kinds of cultural backgrounds in the sense that making meaning of the world. And so the idea is to create a healthcare system that can provide equitable care to everybody, including people who are currently underserved, as well as people who are not. Everybody, regardless of cultural background. Now, structural competence is a more recent term that needed to be added as a corrective in some way to the interpretation of cultural competence that exclusively on an individual basis, as though culture didn't express itself in social structure, which it does. And social structure, of course, also affects the person's culture. But here, the emphasis of structural competence, which is why we now speak of cultural and structural competence, is that care be provided that overcomes the barriers that have been developed over time by virtue of the differences that structures make in people's lives, such as institutions, policies, above the individual level. And this is a focus, as this says, on a systematic practice of exclusion, discrimination, privilege, oppression, etc., and other forms of structural violence. Incompetence, this is a discussion we can always have. What's the best phrasing for this concept of providing more equitable care, whether it's humility or any other, competence or any other. Here, the use of competence is meant simply to indicate that the provider and the system are on the hook. They are responsible for changing their behavior and their systemic practices in order to effect more equitable care, of course, in partnership with the people receiving care. Now I'm turning to the definition of disparities, also to give us a sense of common language. Disparities in the sense of quality of care here is presented by the Institute of Medicine definition, now the National Academies, as the difference between groups in quality of care that is not due to clinical need and appropriateness or to patient preferences. So if there was a difference in quality of care, say in access to care, which was due to differences, for example, in prevalence of the disorder in the populations, or in genuine preferences for one form of care or another, which makes one kind of care more accessible than the other. This sort of thing would not be considered a disparity. A disparity is when there are institutional or professional, personal level, provider level forms of exclusion that essentially are not due to good reasons, such as the insurance limitations or language access limitations and so on. That difference that is not due to appropriate reasons is called the disparity. And I want now to shift, still within the realm of definitions, to the idea of the different levels that you saw were emphasized in the definitions of cultural competence, how the cultural and structural competence approaches to delivering care are should be focused at at least four, there are different ways of cutting the pie, levels. At the level of the individual seeking care, and here are just examples of, you can read them yourself, of the kind of factors that would be affecting, creating disparities in care at each level. Here's at the level of the individual seeking care, at the level of the provider, for example, implicit bias, at the level of the program, or at the level of the system. And it's important for cultural and structural competent approaches to try to overcome gaps and disparities in care, to be addressing these gaps and disparities at all these levels, because usually they're all working simultaneously. And to give you an example of individual and structural levels of access in terms of barriers to access and availability, here's, for example, at the individual level, you might find that Black, Indigenous, and people of color communities might report greater distrust and stigma, alternative views of illness and treatment, and so on, that at the individual level might be affecting access to care and availability. But at the structural level, this is in a context of limitations in, unfair access to health insurance, economic barriers, differences in geographic availability, different structural and systemic limitations in systems of care, all of which are working together, and the system would need to take advantage, work at all those levels. Now I'm going to focus for a minute on barriers to entry into care. Again, as I mentioned earlier, focusing on depressive disorders as an illustration. It's an area that I work on a fair amount, so I know more, have more availability to, know more about it, basically. But this is an example of the level of access and availability disparities that we have in this country. These are data from the CPS, the Community Psychiatric Composite Psychiatric Epidemiological Surveys, which are a conglomeration of nationally representative mental health epidemiological surveys in the US in the last 20 years or so. And this is, as you can see, separated by racial and ethnic background, the percent of people in the last year who did not receive access or have access to mental health treatment, even though they were depressed in one form or another, MDD or dysthymia, after adjusting for a number of other social characteristics. And you can see how it's a significant difference that with non-Latino whites having the least unavailability of access, the greatest access, and culminating, with a spread according to race and ethnicity. And I should say, in terms of all of these data that I'm going to present, is that not every single not every single study finds exactly the same thing, but overall, there's this general tendency for a repetitive finding of disparities in care, particularly affecting African American and Latinos, who are the populations that have been in largest number studied, though it's also affected in Asia when you focus on Asian populations or Native American populations. So typically you find these disparities in care. There are some regional studies that don't find it so much, or find it more for one than for the other, or for one condition or another. But overall, I'm presenting typical examples. Now, here, this is just to let you know, I won't go through all the examples at all because of time. But I wanted to illustrate the kinds of challenges, even with a particular problem, like language access, at every level. You see how at every level, there's an example of the kind of barrier that would get in the way of delivering equitable care, and how these are just examples, among many potential solutions, you could come up with alternatives for addressing each of the barriers. For example, this systematic limited funding for interpreters or in unavailability of meeting class standards can be addressed by all sorts of institutional, systemic, governmental requirements about requiring language access. And this way, through training and a million other things, you can address each of the necessary, each of the barriers that we find. But the key point I wanted to make is the multi-level element of both the problem and the set of solutions that we need to come up with. So now I'm going to focus on engagement. There are three key components. This is just there are multiple ways of cutting this pie. Slicing this pie. There are three components that I like to usually emphasize. I'm now going to focus on engagement as the main topic of this conversation, but you can also have differences in assessment, in outcomes, any number of things. So engagement, to define my terms at the beginning, the way I'm going to use the term, it incorporates various stages of healthcare, including initiating care, so even interpreting there is a problem and getting into care, that's engaging people in care originally, participation in healthcare visits while they're in care, participation in treatment, what is called adherence. If you agree to a particular thing, taking medications, doing CBT homework, that you would do it, and then retention over time. And I wanted to emphasize from the beginning that the multiple difficulties that we have in engagement, the many findings I will be reporting on lower engagement among BIPOC communities, exist in a framework of inequality, so that a lot of it are difficulties that the communities have due to multiple jobs, many experiences of distrust, as well as particular conceptions of illness that are maybe different and don't jive with medical biomedicine and so on. But in general, they're in the context of unequal care for a very long time. And this is how we have to understand people's reactions and mistrust and difficulties with being provided care. And these are data mostly often from national samples that find inequalities over time in being identified as being depressed, where essentially the researchers will interview the patients on the phone in a national sample and get a structured assessment of whether they're depressed, and then they'll survey their doctors and find that the Black patients in particular have not been identified as being depressed, meaning they have a standard research method for defining depression. And when they look at the visit, they interview the doctors, and they look at the visit, the doctor never wrote that they were depressed, they never received an antidepressant, etc. And like that, studies that show that providers ask fewer questions of their Latino patients when they're in care, that Black patients receive less time in assessment than white patients at a national level among psychiatrists. I'll show you that graph in a minute. That they don't receive guideline concordance care, also in national studies. Again, not every study finds this every time, but most of the time these things come up again and again. This is the study that Mark Olson and I and another colleague did some years ago, about 10 years ago, where we looked at, I won't go into in detail, but it's a national survey of psychiatrists in the US. And the psychiatrists are asked on a randomly selected week to describe the care they provided to their patients. So these are the psychiatrist's own report. And what we found is that there was a difference between Black and white patients in visit duration. So that, and these are the characteristics, the variables on which the visit duration differed by race. So for example, the biggest duration of about 10 minutes, that's this bar here at the top, 10-minute difference between whites and Blacks after adjusting for a number of other factors, was for adjustment disorder diagnosis. If you came into a psychiatrist in this country and you were Black with an adjustment disorder diagnosis, after adjusting for every other factor, you would get 10 minutes less of psychiatry time, basically. And like that for every single one of these factors. So that it added up over that time period to a 7-minute difference in time overall between Blacks and whites in time spent with them by psychiatrists in the US. Now that difference had shrunk by this time period to a negligible amount, and it had shrunk because the Black patients came up in time, not that the white patients came down. It wasn't that the white patients got less time like the Black patients got more time. So possibly at that point we were hopeful. Remember what time period 2006 and so on was. 2009 was the beginning of the Obama presidency. We were hopeful that this indicated some sort of systemic change. Now it doesn't look that way, and I wonder what it would. But essentially, in addition to all these structural and systemic issues, remember that these are psychiatrists providing their own information. It's very interesting that they may not even be aware of the fact that they are providing less care, less time to patients of one race versus another. Here, it's a good point to bring in the topic of implicit bias and the difficulty that this has in creating or in perpetuating health disparities, let's say perpetuating health disparities, in the sense that a pro-white, anti-Black implicit bias has been found among healthcare providers using the implicit association test, which many of you are familiar with. And these are associated not always, but often with differences in empathy or therapeutic bond and treatment recommendations. And in general, the most consistent finding across these studies in this meta-analysis is with poorer patient-provider communication. So this is an issue at the provider level that we need to be very aware of, that can be addressed at multiple levels. You can have a systemic, initiative to reduce implicit bias, but it's a factor that seems to affect provider level quality of care. Now, here's an example of, I'll give you another couple examples in the engagement field, and then I'll move to, I believe at that point I move to strategies, but these are, to address them, but these are examples relating to difficulties in engagement among initiating antidepressant prescriptions. Another nationally representative sample where essentially a population who has been found out to be depressed by a research assessment is then followed up to see if they fill a prescription for antidepressants using an electronic medical record pharmacy prescription system. And what you find is, and this is rather striking, is that the odds ratio for Latino, this is the blue, and African American in the teal, and then gray is other ethnicity race. It's significant for these two because of the, I'm sure, lower number and heterogeneity of this population, even though the absolute odds ratio is smaller. But you see a very, even less than 50%, like 40 point, an odds ratio like 0.48, lower likelihood of filling an antidepressant prescription among people who are depressed, after adjusting for a number of factors, in this case, age and insurance type. We don't know, and it's a limitation of these studies, whether they don't fill an antidepressant prescription because they didn't get an antidepressant prescription, or because they got an antidepressant prescription and didn't fill it. But either way, and it's a very important difference, and it's a limitation of this kind of work. But either way, it's important as indicating the level of engagement difficulty that we have in certain populations. Here's another example focusing on retention. This is also work by Mark Olfson, another national representative sample aggregated over several years. What Mark and colleagues did was find out people who initiated an antidepressant prescription, so these are new prescriptions, and see how many of them stopped the antidepressant treatment within 30 days, again through pharmacy records. And what you find in this case, you see in this case, for example, the Hispanic group is significantly different than the white group, whereas the black group, although lower, has a wider confidence interval and is not in this case significantly different. But this varies from study to study. It's just usually it's one or the other or both are usually found in this way. Language also affects. So among Hispanics, for example, English speakers tend to have better engagement than Spanish speakers, and so on. But in any case, in this study, you see that the Hispanic group is more likely to not continue their antidepressant past 30 days after adjusting for a number of factors here. This is also a nationally representative sample. So here are other inequalities that I'm not going to give you examples for. In general, from pharmacy records, lower medication adherence among racial and ethnic underserved communities, lower percentage of visit participation. These are typically older studies that need to be redone, lower continuity of care, and so on. And this presents many alternatives for possible solutions focusing on engagement. Here are just some, and I will illustrate these with examples in a few minutes, but there are many ways, including, for example, this primary care one, integrated care being good for everybody, especially people who have limited, availability of going to care because of multiple jobs or healthcare, childcare responsibilities or a million things, or mistrust issues with mental health care or stigma and so on. But it's particularly good for populations who are more underserved than others because it addresses those barriers sometimes more directly. I'm going to spend most of the rest of my time speaking about this, specifically cultural tailored interventions focusing on engagement. But first, a summary. Again, the same idea to show you at multiple levels. And this, in some ways, is a bit of a guide for some of what I will mention next. I'll mention Decide, I'll mention motivational pharmacotherapy, but some of the others I won't spend more time on. You see the levels, the challenges at multiple levels, and then the different kinds of solutions that can be provided at every level. And they are not mutually exclusive. One could provide, you know, if the problem is at multiple levels, it might need a multi-component. It should be, you know, it would be much better if it had a multi-component solution. So the second half of my presentation involves strategies to overcome disparities in engagement, and I will focus at each of the 4 levels. And here are some examples. I will spend time on Decide, on motivational pharmacotherapy, briefly, the cultural formulation interview, and these 2 as well, briefly. But you see at every level, there are different strategies that are being developed that could be implemented. They're all at various stages of development. Some are promising. They have a very good pilot and a second follow-up that shows the greater difficulties involved when you try to scale them up. They're all in development in one kind or another, but they're approaching over time different, you know, more levels, more data as evidence for their efficacy. At the patient level, Maggie Alegria and her group has developed this very interesting approach that is focused on the notion, it comes from a work in education, focused on the notion that people don't necessarily, with a particular concern, don't necessarily empower themselves fully when they go seek the help of an expert of some kind. They don't necessarily prepare their questions. So in education, this created a community-based, practice-based evidence sort of approach called the Right Question Project, where the idea was how to empower through a coaching system how to empower parents to go to their schools with questions about their children. So how to create the right question before you went into your appointment with the teacher or the principal or whatever. And so Maggie developed this with her group for how can a consumer frame their question for the provider before they go into mental health care. And this is a care manager-based approach of 3 interventions where of 30 minutes each, where the consumer is coached. They incorporate these different methods, role play, homework, cultural components, CBT, etc. And they tested it initially in this large 231 mostly Latino patient sample with 6-month follow-up with different diagnoses. And essentially, they had a quasi-experimental design where one clinic got this coaching system and the other clinic did not. And remember, the idea is the patients are coached as part of a process during the beginning of their mental health care to come into the provider with questions about their care, things they want to know about how to change or improve and so on. And the idea was that this would improve their engagement as well as some of their outcomes. And what they found was that not only were the patients who do this more empowered and more able to self-manage their situations, they actually in this pilot had better retention and better attendance, which was a very exciting pilot because here is overcoming engagement problems. So Maggie put together this larger study with 647 patients in 13 clinics in 5 states plus Puerto Rico. We were one of the clinics here at Columbia. And she found, of course, as these things are often do, which patients were randomized, that it very complicated, so that she reproduced the work on empowerment and activation, but did not reproduce the findings on retention and engagement. So when you spread it out and you randomized by the patient at the patient level, you ended up with non-significant differences in retention and engagement in the larger study. Now, Maggie interpreted this partly as being related to the fact that the providers didn't receive the patient's questions very well, meaning that the patients had been empowered, as shown by the findings, the self-reports, to ask questions, but the providers weren't ready to deal with the patients in a different way than they had before. So then Maggie obtained a grant to create a training system for providers to address patients' more activated questions. And so this is now something that is in the process of being completed. But it indicates the difficulties that you have when you go from an initial set of findings to a ramping up a larger thing. You run into many different implementation questions, in this case, the provider participation that needs its own component intervention, in this case, how to enlist providers in this process. A study that we've been carried out for some time is on motivational pharmacotherapy, which, as many of you know, many of you know motivational interviewing, which is a system for engaging individuals in change, in, let's say, therapy, because of the kind of work we're doing here, but it could be different forms of change, that tackles the person's ambivalence, where non-engagement in this case is conceptualized as ambivalence. And the notion is the person is going to be helped through a series of MI-related processes, which are mentioned here. The person is going to be helped to evoke their own motivation, meaning get barriers out from their own motivation, eliminate the barriers or reduce the barriers that are hindering their own motivation to engage in change. And to do this, there's a certain system that was developed by Miller and Rolnick and others to non-confrontational, motivational process that deals in a certain way with resistance, develops discrepancy, works with their strengths, and so on. It's a form of therapy that has become more and more used over time for different kinds of approaches. Our work has involved combining motivational interviewing with pharmacotherapy, initially for depression among Latino patients who are depressed, so as to engage them better in care. Essentially, let me give you an illustration of the kinds of comments that an MI-consistent pharmacotherapy would do, as opposed to a regular pharmacotherapy. So pharmacotherapy, I just mean medication treatment for depression with antidepressants typically. So a person comes in for care after having taken these medicines, say this is their second visit, and says, I have now been taking these medicines for almost 10 days and I still don't feel any different. Now, at this point, I typically open it to the audience. It's a little bit difficult when everybody's muted, so I'm just going to say it myself. But essentially, what would be the sort of thing a regular pharmacotherapist would say would typically be something like this. Sure, it's important to understand that these medications typically take a few weeks until they begin to work. Kind of an educational, well-intended approach of reassuring the person, don't worry, it takes time for it to work. What an MI-consistent approach does is something rather different. We start with the same question, but instead of educating, and therefore in some ways the notion is ignoring the person's emotional state to a certain extent, we roll with the person's emotional state by providing an empathic reflection and say something like, you're not happy about this. You've gone through the trouble of meeting with us, filling your prescription, taking your medicines, and at this point you really want to feel better. It's essentially emphasizing the person's agency and desire for change and recognizing and acknowledging their feelings. I've neglected to thank Alex and Terrian, who's one of my partners in crime in this sort of approach over time, who provided these examples from actual clinical care. But you see the difference, the ways that MI essentially incorporates almost a psychotherapeutic approach to the typical pharmacotherapy session. Now, what we did also in terms of the structure of MPT is we focused on what is called evoking change talk. This Terry Moyers, who's one of the creators and systematizers of MI, worked with us on this. And the idea is that over time, it's become clear that MI seems to work partly through evoking change talk. The person acknowledges the need for change and makes a statement and set of commitments and eventually moves on to take this position of making a change in their life. And to do this, we have a number of exercises, one of which are these value cards, where we ask patients to select a set of values out of 34 values we obtained from formative, qualitative research with this population about values that are common in this community of low-income, depressed Latino patients who are coming to our clinic. And these are some examples of them, you know, helping family in my country, being well-educated, which is a certain formulation in Spanish of politeness and sensitivity and so on. So essentially, we give them to choose these options and we say, pick 3, and then we say, tell me how the depression has affected these values and goals, at which point they tell you, oh, I can't do this, I can't do that, I'm so much awful about that. And this is a way of creating discrepancy, you know, heightening the discrepancy in their experience between their desired state and their current state to evoke change talk. And so this is an example of the kind of thing that happened in this case. I wish all the examples that we did were as neat and quick as this. Obviously, this is a very, it happened, it's a real case, but it's a prototypical example. You saw the early part of this, that was the empathic reflection where we left it off, and then the patient starts going to change talk after such a nice empathic reflection. Yes, I definitely want to feel better. I hate feeling like this. At which you see the discrepancy has been heightened, basically. At which point the clinician doubles down with another reflection, empathic reflection, and says the depression you're going through is really making a difference in your life, underlining the discrepancy, at which point he says, I know I've had enough, I'm ready for a change. You see what I mean? So it's the kind of, this is where you want the person to be. You want to evoke their own motivation to commit themselves to treatment in order to improve their lives. And so that's the nature of what we're doing MPT. There are a number of cultural adaptations that we included, including these cultural understandings of illness, using their own illness terms, negotiating the expert role and power differential. You know, you may presume that patients will, if you ask them to make decisions, patients might say, well, you know, what do I know? You're the doctor, you tell me, especially many Latino patients expect this from their clinicians. But we found ways of addressing that, like, for example, by saying, well, yes, no, sure, we are the experts on this medicine, but you're the expert on you know, how this medicine is affecting your body, what sort of reaction you're having. How would I know what reaction you're having? You know, so we got to work together. You know, I have an idea what it might be, but you got to tell me. So creating these places where people could meet and negotiate care. And then these other examples of kinds of cultural adaptations that we implemented, including, for example, this bottom one about expectations from nerves, the treatment of nervios in the Latino community, about how medications from nervios might work. We were really flexible in terms of following their lead about increasing doses, using as minimum a dose and duration as possible, while at the same time adhering to guidelines about duration and general efficacy. So these are our results from the pilot. I'll show you, essentially the black line at the top here is the retention for MPT. It shows you a 20% drop, discontinuation of care at 3 months. Whereas the previous trials in our clinic, this is the Hispanic treatment program with Spanish-speaking clinicians, sometimes the same clinicians with different medications, as you can see, had a much lower rate of retention over time. We then did an R01 that we're finally finishing the analysis of, and shows some impact on retention, but less in some ways than this. It seems like this is partly determined by their previous experience with antidepressants. If they've had a good experience with antidepressants, this MPT is less of an issue than if they haven't had much of an experience in the past, then it seems to have a bigger effect. So that's what we're working on at the moment. Now I'm going to mention briefly the cultural formulation interview in the interest of time and to leave some time for questions. It's another provider level approach. It can be implemented at the program level. I'll mention that in a minute. But so I've stopped talking about MPT. Now I'm going to talk about the CFI, which is this systematic set of interviews to guide cultural assessment as a way of engaging people in terms of engagement by eliciting their views of what the condition is, what brings them into treatment, what is it they expect from care, what does the family think they need to do, what has gotten in the way in the past, essentially ways of evoking from the person their experience of illness and their expectations of care so that we can incorporate it in a negotiated way and therefore increase engagement. And these are just, the map is where all the places where we did the international field trial for DSM-5. But the graphic on the left essentially shows how there are different components of the CFI, one devoted to the person, one to the companion who can provide additional information, and then there are also supplementary modules that can expand the assessment. But I will mention the content of the core CFI in a minute. There's 16 questions. But first, I just wanted to tell you that in many ways, these are the goals, which are essentially to, I mentioned before, to elicit all these aspects of their experience, including the way they refer to the situation, this use of the patient's vocabulary, which you may remember if you were really paying attention was part of MPT. Also, it's a way of evoking their participation by calling the thing in the way that they call the thing, as opposed to introducing a barrier there. And all these different ways in which we can enhance engagement by evoking the person's story and a set of decisions about care. So these are the components of the core CFI, the 16 question interview that is focused on the individual seeking care. Remember, there are two other components for companions and for a supplementary module, but these are the components for the person seeking care, involving a definition of what's going on, cause, context, and support, cause, context, and support in the past, including and present, including the role of cultural identity in the presentation and expectations. Then in terms of what they've done in the past to seek care and what got in the way, and what is it their preferences for the moment, including going forward, including the relationship with the provider. So these are a systematic, a standardized assessment, basically, for a cultural psychiatry assessment, cultural mental health assessment, to get their perspectives and care. We've developed a training module in collaboration with the Center for Practice Innovations at PI and the state, which we are happy to provide free of care if you are a provider in New York State who's working in the public mental health system. That's the orange link below, and the teal link above is if you're a private provider or in another state or whatever, anywhere in the world, you can go into our website, pay a minimal, we feel, amount, and have access to the training module. We're very happy. These are there are 4 of them are pictured here, 5 real people who participated as part of their recovery process. They wanted their names mentioned. They told their stories. They're farther along in the process of recovery than the stories they told, but they acted as if they were in a previous stage of their recovery when this would have been very useful, whether they were in an emergency room or entering outpatient treatment or in an employment center and so on. And the idea is that the CFI can be used by any provider in any clinical setting with any patient. We feel it's most usefully done at the beginning, so as to of the assessment, to get the person's story, to enlist the person's participation, to evoke their sense of what's going on. So that's the cultural formulation interview. And that ends the 2 examples I gave at the provider level. At the patient level, I gave the DECIDE example, Mike Alegria's activation protocol. At the provider level, I gave the example of what the motivational pharmacotherapy, the provider could do to incorporate MI into medication treatment. And I also gave the example of how the provider could enlist the patient's story by asking all these questions of the patient, of their companion, the family, other people, about what is it they expect from care and how is it they understand the situation, what got in the way in the past, and so on. At the organizational level, if you will, there are different things that can be done. One example that I like is this cultural consultation services. They're active mostly not in the United States, but they are quite active in Canada, in Northern Europe, and so on, where you have a service devoted to overcoming disparities in quality of care for often immigrants or refugees. Typically, that is the the frame, but it could be anybody who is culturally, if you will, at odds with the biomedical system. And essentially, it's a systematic way in which a program is created to develop a different kind of assessment, involve interpreters, cultural brokers, a case discussion, and provide feedback back to the person creating the referral. Often it's the provider making the referral, and all these aspects of care. Here are some of the components that I mentioned: interpreter, cultural broker, the assessments involving the family, a cultural formulation approach, case discussion, and so on. In one very good study that appeared in Psych Services a few years back, they looked at the results for psychosis diagnosis over, before and after the referral, and they found that 49%, almost half, of the people who had been referred to the service at McGill with a psychosis diagnosis were re-diagnosed as non-psychotic. And only 5% went the other way, meaning they came in with a non-psychotic diagnosis and left with a psychosis diagnosis. So most of the time, as is known from findings in the US and other areas, particularly with African American patients, there is an overdiagnosis of psychosis in certain situations that the provider is unfamiliar with. Either they're referring to things the provider doesn't know about, like witchcraft or whatever, or has a particular opinion about, or they look in a way they shouldn't, or they don't communicate in the way that they feel they should, the provider feels they should, or they have a question about whether the person is psychotic or not, or any number of other conditions. And in this case, most of the time they were not psychotic. Well, half of the time they were not psychotic. Most of the time, those people had some sort of post-traumatic stress type or adjustment disorder type condition, often because of experiences of trauma. So at the community level, and I'll close with this and leave maybe 5 or 10 minutes for questions, discussion. At the community level, I'm just giving the example of the Community Partners in Care, which is a very nice study that Ken Wells and colleagues are doing at UCLA. They now have even a follow-up study, but essentially it's a very tailored, very focused look at whether a community-focused approach of engagement of the community through a series of very specific community-based participatory research type approaches of meetings with the community on a regular basis, twice a month, different community organizations, sharing leadership and responsibility with the community partners and so on, whether that kind of approach outperformed a simpler train the trainer approach in which the community, the other randomized half of the community organizations were provided a set of workbooks and skills and so on for how to train their people. Everybody was given these trainings, but in one group, the experimental group, they were also given this more community-based approach that enlisted them in running their own, essentially participating in the running of their own program. And what they found, and these are these many programs and individuals involved over here, after adjusting for a number of factors, that there were a number, at 6-month follow-up, a number of domains on which the experimental arm, the community-focused arm, outperformed the train the trainer approach. Couple areas where they didn't had to do with service use, antidepressant usage, employment. There were a few areas where these didn't outperform, but in actual 4-year follow-up later, they did find greater remission of depression in the people who participated in the experimental arm. Initially, there was more mental wellness, quality of life, homelessness, and so on that were affected. But over time, they actually saw also an outcome involving remission using the PHQ-8 in this case. So, in conclusion, I hope I've shown you how cultural and structural aspects of care can affect engagement, how established engagement strategies should be enhanced with cultural structural competence approaches, how we are developing, the field is developing interventions at all levels to try to address this. How they show promise in closing the disparity gap while at the same time revealing just how difficult this problem can be, and how a single level intervention is often insufficient. And also something shown from the community-based work, how partnership among all stakeholders is essential for success. And I just wanted to leave you with this slide, inviting anybody who's interested in submitting column submissions to psychiatric services. I edit a column on cultural and mental health services, and I'm very happy to answer any questions or address anybody who wants to email me about that. Thank you very much for inviting me.
Roberto, thank you so much for that really wonderful presentation with so much information at all levels on how to intervene and address health inequities. Thank you again. I just want to sort of just say thank you on behalf of all of us at the Implementation Science Initiative, and just also acknowledge that this is a shared effort between all of us, as well as Milton Wainberg, who's at our institution as well. So thank you, and I just want to open up the chat room to see if there are any questions. Please feel free to chat. Okay. And we will try to, okay, I'm just opening up the chat now. Okay. Roberto, I have a question for you. Has the CFI been used, to your knowledge, within any of the organizations here within the state? Has it been used as part of a pilot or any kind of quality improvement program that you're aware of?
Yeah, the Urban Institute uses it as part of its health record. I don't have information about whether they've done a pilot on it. Mm-hmm. We did a pilot at one of the psychiatric centers upstate at their request. They were very interested in being trained. So we enrolled a number of their providers there and found some interesting things in that they were bombarded, as everybody knows, with work and different requirements for, fill out this paper by 72 hours of admission and so on. So what when we did this kind of qualitative implementation based approach, where we interviewed multiple times over time as we trained them in the CFI, and then they implemented it over time, we discovered that several recommendations that they made to the OMH system, particularly flexibility. That for some patients, it really makes sense at the beginning, and for many patients, it does not. That the forensic units had a harder time in this than the civil units. We'd used it in both. That many of the forensic patients weren't very ready at the beginning to be participating in an effort to find out what they really thought about care, basically. But that over time, perhaps for some patients, it would be more useful upon discharge or halfway through their process, that the goal and the timing be something that be flexibly allowed as opposed to required. That was one of their main recommendations. There've also been different studies in different parts of the world, like the Scandinavians are big on this, and they've done different, in Denmark, they have a series of studies about implementation, who uses it and what questions come up, which ones are the questions that people have a harder time with, which ones they incorporate more easily. Other studies have had to do with, in Sweden, refugees versus, meaning Swedish speakers versus non-Swedish speakers, sort of natives versus immigrants, and whether it's useful for both, or is it better for some and not others. They've been doing this kind of work.
Mm-hmm. That's great. I mean, it's very interesting. I mean, what you're pointing out are some of what you would imagine are the barriers and facilitators to doing some of this and incorporating it into like a workflow for a clinician that's trying to understand the client's perspective and understanding their of their own illness or their problems. So that's very interesting.
I have a comment, if I may.
Sure.
Okay, thank you. So Roberto, I thought it was beautiful. You packed a lot into this session. It was beautiful, and I'm very excited to think of what we learned with working with disadvantaged populations that are not part of the medical culture, right? You know, and they're another culture, and we want to understand and make sure that we pay attention to them and not to what we think is their culture, which we have done traditionally in medicine and mental health. So I'm going to invite you to work with us in Mozambique, where we are expanding from providing care in, I don't know, 20% of the country in mental health to the other 70 to 80% of the country. And I want to make sure that we don't make the same mistakes that we make here and we have made here. So instead of going, you know, starting our work 30 years ago or 50 years ago, now, can we try to learn from what you have so beautifully put together here today and figure out how do we engage the populations to take care of them and not what we think or those trained by us, quote unquote, right? You know, with our biases, because as Latino, and I think I could be not so biased, I still bring bias, and I want to make sure that we don't bring our bias. And I would love to invite you and your team to think with us in how do we do that, because we're going to meet a population that is, you know, naive to treatment, to mental health treatment, and we want to make sure that we pay attention to them and not to what we think we need to do.
We'd
So
love to
it's
do
an
that.
invitation.
Thank you, Milton. We'd love to do that. I'd love to do that. That sounds great. Whenever you want.
Beautiful.
So we have one question, one last question that we can take. I'd be interested in how you think about technology, telemedicine, and affecting engagement in this population. And this question, I think is NM2562. Is that Natalie?
Natalie.
Hi, Natalie. So Roberto, how does technology and telemedicine affect engagement in this population?
It's a very good question, and I don't have all the answers in this area at all. It's an area that is fairly new to many of us. We're especially working with this population. Little by little, I think the major barrier will be for the older population, as is true for almost any group, that many of the older people who have a limited computer literacy might find some of the telehealth challenging. I'm not sure whether it is particularly greater in some racial and ethnic groups than others. I don't know that. It might be, but I don't know. I think the age gradient will be something to overcome. And also, just speaking a little bit personally, maybe, is that there is a certain personal rapport that is a key element of at least the Latino experience in mental health care, which we would need to work very hard to reproduce on a telehealth basis. I think it is possible to create, but there is a certain warmth that is expected and needs to come through, that the provider cares for the person as a person, not as a instrumental element of, you know, expertise. And that I think we have to develop a way to reproduce that in telehealth in order for there to be trust established. A lot of the trust, confianza, and so on, is people have written about, is established through this warmth and caring aspect, which sometimes I find the telehealth approach, you know, creates an extra barrier if you don't overcome it.
Great. Well, thank you again, Roberto. I see we're at the top of the hour. We just want to thank you again. And thank you all for joining us. Our next seminar will be on October 2nd. And there will be some listserv emails that will be going out to let everyone know about that. So thanks again, everyone. Have a good rest of the day.
Bye, everybody.